Okay, I want to just welcome everybody to tonight. We got lots of people here, which is exciting, and a lot of people also on Zoom. So this is something that is a passion of mine, and I just get excited to just talk about it. The title tonight is Using Precision Psychiatry to Improve Mental Health. And that's me, board certified in psychiatry and addiction medicine, been around Charlotte County for over 10 years. A lot of people know here when I first started. So it's exciting, that now I can have a chance to share what I've been doing. Excuse me. Okay. So before I begin, I just want to have a little fun and let's just talk about the history of psychiatry. And I don't know if anybody was here the last time. So if you were here last time, don't say anything, Anyway, so let's have a little fun. Let's talk about the history of psychiatry treatment. This was what, 7,000 years ago. And can anybody make what's going on here?
Trepanation.
Yes, very good, very good. So what it is a process of removing a piece of skull, the purpose of letting the demons go, I guess, and also relieves headaches, right? So that was back then. So the next thing we move up to is what we call, I'm sure you all know this one.
Bloodletting.
Yep, bloodletting, okay. I'm trying to. All right, that is a theory in 1600s that, it is a chemical imbalance, and releasing that through your blood was the way to cure mental illness. Well, they got half of it right. It is a chemical imbalance, but the method, not so much. So let's move on to 1948. This guy, he invented the first psychiatric medicine, and anybody know what it is?
LSD.
Not quite, All right. It is lithium. Yeah. So invented by John Cade, an Australian psychiatrist. But 2 years later, they came out with the first. This is the organic chemistry of it. It is an MAOI inhibitor. And interesting enough, the first MAOI was called iproniazid. And they found it by accident. I was like trying to do this lecture. I learned quite a bit about the history of psychiatry. A lot of it is by accident, So iproniazid is a derivative of, it was actually a tuberculosis drug, sister of was it
INH or rifampin?
Yes, INH. Yes. So they gave it to these tuberculosis patients. They saw wow, they feel good. They're looking happy. I was like, wow, let's make this into an antidepressant. So later on in 1952, oops, sorry there. Okay. Is that not coming up here? Okay. Well, in 1952, we have the first antipsychotic called chlorpromazine. Anybody have an idea where that came from? All things Benadryl. Yep. So that is the first antipsychotic. And then we move on to the TCAs, which, it came from chlorpromazine. So it's interesting to see that there's evolutions of all these psych drugs that came from each other or by accident. And, TCAs are great for what? What do we use it for now? Depression, but does anybody really give TCAs? Exactly, because it is very sedating. The higher you go, yes, the more effective it is, but then they're sedated. So it wasn't the best thing. And it's dangerous, overdose, you got arrhythmias and so forth. So in 1987, came out with Prozac. Pros, less sedating, it's safer. Cons, you still have bad side effects, sexual side effects, sexual apathy, all those things. So they, as we know, we moved on to the SNRIs, and we got the I think Trintellix is in its own, while Wellbutrin is in its own. However, despite of all that, we still have to figure out how we get our patients better. So just for kicks and giggles, let's talk about, non-medications. We got Freud, right? He revolutionized psychiatry, added psychotherapy to it. It's a good modality. However, if the patient I have patients all the time, so tell them, hey, you need to see a therapist. I can't focus. I can't concentrate. I need to get my brain better before I can even do that. And so there are barriers to it, but it works very great. And of course, we know ECT. This is also an interesting piece of trivia. Anybody know what they use first to induce a seizure? It's insulin. Hypoglycemic shock, seizure. Of course, now we have a little bit safer method to do it now. Okay. All right. So lobotomies, as we know, I was told that it actually still practices in parts of the world. And obviously, the whole point was fix the brain, the frontal lobe, fix the psychosis, but we did more harm than good because it left people incapacitated. The most famous one is Sister JFK, institutionalized the rest of her life. Sad, sad. So we have all these options for treatment and medications, non-medications. The question is, despite of all these treatments, why is it 10 million Americans are still depressed despite all of these treatment options? And can anybody tell me what is the rate of treatment-resistant depression with people who are diagnosed with MDD? It's 50%. Interesting enough, in 2000, it was only 25. So we're getting up there, even though we got all these great advances. So I'm wondering to myself too, what is going on? So I saw this in my own practice, okay? 10 years here of outpatient in Kentucky. Patient get resistant to meds. So I just kept on trudging on, trying to figure out what is it we can do to get our patients psychiatrically better. So I looked into DNA. In the beginning, it was all about red, green, yellow, or, all those things that how I used it before. It didn't work because I didn't understand the pharmaco dynamics of it. The other part of the genetic test, which I'm actually looking more now about metabolism, how people respond to brain injuries and so forth. So, and how people metabolize all our serotonin, dopamine, epinephrine, especially dopamine. Dopamine is very important when it comes to treating mental illness. So that was my beginning stages of genetic testing. So then I added integrated medicine for mental health, otherwise known as holistic psychiatry. What is their lifestyle about? Are they drinking, drugging? Are they eating well? Are they sleeping well? What is their medical status? Are they inflamed? Inflammation, brain inflammation is a new thing that everybody talks about because it's just like arthritis with the joints, your brain is inflamed, you are sick. You're depressed, you're anxious, you can't think, can't concentrate, don't want to do anything. Certain viruses can cause this, nutritional status, and we're talking about vitamins, or can they metabolize certain vitamins in order to make your good feel hormones? But I found out supplements were still not enough because in a way, I still wasn't connecting it with all the other factors I've learned. So I added TMS, non-medication, non-invasive for treatment-resistant depression. Latest data says it does have a 20% failure, which is still good because most psych meds are 40-50%, right? Targets the DLP, releases serotonin, dopamine, norepinephrine, and it also affects GABA. So there is a reason or indication to say that it can treat anxiety because of that mechanism. And if anybody's seen the movie Quiet Explosion, it's about traumatic brain injury. I was excited to see somebody put a TMS, section in there. And I learned something there that actually, that it does also heal the brain. And I found out why. It's because it promotes BDNF, brain-derived neurotrophic factor. And I'll talk more about that later as I get on, but that was exciting. So as far as what I do, I try to make sure if I'm going to do it, I want to know the results. I want to know how it's done and the benefit for my patients. Okay. So last but not least, so I finally figured out the missing link, hormones. Okay. My mentor said it's not treatment resistant depression until you check their hormones. You know, you give them all these meds, do TMS, and they're still going downhill. A lot of times it happens with traumatic brain injury patients. I learned to appreciate that question to my patients now. You know, when they tell you, I haven't had a head injury. Have you had a fall? Have you had an accident? Have you had whiplash? You know, even when you fell at 9 years old, it's there's still an impact maybe 10, 20 years later because you just jarred that brain inside a skull full of jagged edges. And we do believe in plasticity of brain now. It does like heal itself, but we have to give it that neuropermissive environment in order to get there. And at times when the brain doesn't function, the hormones don't function, you're depressed, you have low energy, and so forth, can't focus, can't concentrate, because there's a lot of, I would say, benefits to hormones other than what we all think it is, okay? And I wanted to just mention, if you have a traumatic brain injury patient, male, you better be checking their testosterone, especially when you're like, I can't get this patient to be better. You'd be surprised. So, full circle, this is what we've done. We started with genetics and TMS. We got the hormones and we got integrative. Believe it or not, one affects the other. And I can look at somebody's genetics and predict maybe some of their hormone levels, what I think they would be. Not 100%, but like I can understand why some things would be the way they are if I looked at genetics. When it comes to TMS, I won't even do it unless I know what their genetic status is, because it won't last that long, or it won't work at all. Because certain genetics are prone to not respond, but if you support the body through supplements, it can do a better job. And then, we talk about the hormones. All that still is full circle to how one affects the other, genetics, so forth. So what we come to is the Paradise integrated treatment using precision psychiatry. So why do we do this? Why do we treat precision psychiatry? We use precision psychiatry. First of all, it's the practice of using biomarkers to get to the root cause of why someone is depressed, anxious, or moody. And those biomarkers are what we talked about. They're just measure of values that guide a direction of your treatment. So as I've come to realize that mental illness is really also an illness of the brain. Any insults to the brain, accidents, infections, stress, the brain gets inflamed. And if we don't give it a chance to heal, then you're going to have those symptoms that get sent to psychiatrists for. Depression, anxiety, can't sleep, can't concentrate, suicidal thoughts. Suicidality is a huge thing. It's, as you know, with these NFL players, suicidality is a huge, huge thing that happens when you have a brain injury. So I come to appreciate that, how much an impact a brain injury does for suicidal ideation. So the goal is we want to use an integrated program to heal the brain with the most comprehensive treatment plan. So how do we do that? We get the evaluation, get them in, and we create the treatment plan. Simple, sort of. Okay, so the psychiatric evaluation, we talk about symptoms, we talk about their psychiatric history, medical history, what's going on. COVID is a big thing now. And the reason why COVID causes that COVID brain is inflammation in the vasculature of the brain. It's really, and sort of like what happens with, vascular dementia and so forth. And it's just a breakdown of blood vessels to the brain. So we have to support that with antioxidants and so forth. And of course, we talk about what is stressing them. Are they being abused in a relationship? Are they in a toxic relationship? Is it supportive? All those things matter in order to get an understanding of what the patient is about. You also have to know what they're eating and whether they're really taking care of themselves. I can't give somebody as many pills if they're not doing something to try to help themselves take care of themselves. That's not going to work either. So the next thing we do is a depression panel. We created this as in our office, specifically for our practice. We check for the usual things, CBC and CMP, and there are times we do have to give antipsychotics. So we do run the hemoglobin and fasting lipid panels and so forth. Most important though, we look at vitamins, look for vitamin deficiencies. We look for, are they able to metabolize them, especially the B12 and folate. So sometimes it's moot point to give somebody B12 or folate when they're not even metabolizing it. You're just, wasting their money and resources. So with genetic testing, there's like 3 of the main components of genetic testing I really look at. The MTHFR, I think everybody already knows about that. Are they metabolizing their folate? Because it's not only just that. Folate will take homocysteine, becomes the amines, serotonin, dopamine, norepinephrine. That's why when I see somebody with a folate level that's on the low end, I supplement them. Maybe they're just not making enough, right? But also, if they have, the deficiency, what's the point of giving them folate? Because it's not gonna work. And I see this sometimes in labs. I see their folate is like way high. And I go, I suspect this patient is MTHFR, and they are. So, but we don't know that until we run the genetics. And the other really interesting thing that I look at is the COMT gene. The COMT gene is interesting. It metabolizes 2 things, dopamine and estrogen. That's just the weirdest thing, but it does. So whether you're high or low, it's a totally different picture. When it's high, you get this thing where people look like they have ADHD. They can't sit still. They're restless. They're out there, trying to give themselves dopamine, jumping off buildings or, surfing and all that. That's what happens. So in a way, I call that the ADHD gene. The opposite, when it's low, your dopamine is running rampant. What happens? These are the people that have difficulty adjusting. They're anxious, and that's what happens to them. And they have a lot of good qualities in them. They are obsessive. They're good workers. They can function well so long as they have a supportive environment. So the other word for it is what they call the warrior gene. So when you look at that, you have to understand, because one or the other, the treatment is totally the opposite. So, and the other thing I look at is the BDNF gene. What is their BDNF altered or not? The BDNF is part of the connections of the brain, as well as the plasticity of the brain. Believe it or not, there are people who have altered BDNF, meaning they don't work as well. So maybe that's why they can't recover from brain injury compared to somebody else who has normal BDNF. So that to me was the 3 important things that I really look at genetic testing, just to see what's going on. And the good news is the treatment really is a lot of natural things that we can just feed ourselves with. And so that's the best part about it. I have some patients who don't take any psychiatric meds because I found out this, all this stuff was part of their genetics. And also they're vitamin D deficient. And fixed all that, happy. So there's ways to go about treating depression other than reaching for the next psychiatric med. You know, I'm not against it. Sometimes we have to use it in order to get the patient to the, you know, out of that. But I want to look at what is going on behind all that. So last but not least, the hormone panel. I talked about genetic testing, how you can predict whether some levels will be high or low. Mostly though, it's through the COMT gene because it breaks down estrogen. So these are the people that will have elevated estradiol. I've seen it, even in males who are very anxious. So we find ways to bring that down, anxiety goes away. Of course, you know, there's also interplay of vitamin D and Hashimoto's and so forth. Lots of things to look at. We look at the pituitary hormones, thyroids, adrenals, and your peripheral sex hormones. We want to know what's the relationship between the two. If your pituitary hormones are low and your peripheral hormones are low, then you know it's coming from the brain that is not working right, whether it's head injury, inflammation, or whatever is happening to the insult of the brain. And if that's the case, we have to support the brain in healing itself because it can happen. Okay, so the goal of what we do after we did all that workup, look at everything, tie it all together. We want to, as we discussed, talking about decreasing brain inflammation with antioxidants, you know, the usual vitamin C, D, zinc, glutathione, and acetylcysteine. It all depends on how the patient responds. So the other thing is when it comes to antioxidants, green tea, anybody know green tea, right? It's not good for some people. It makes them more anxious. Why? Because it is a phenol. A phenol makes dopamine. So ever hear how some people say, I can't have coffee because I get palpitations? That's why. Or you have those patients that got more anxious, get a little bit hyperactive when it comes to Wellbutrin. I think some of us have had that. That's why. Because they cannot tolerate or metabolize the dopamine that's coming from the Wellbutrin or green tea. And so those things we have to be careful with. This is why I say we have to look at their genetics in order to see whether they will respond or not respond or have a bad reaction to their treatment plan. So we got to be careful. So we talk about diet. Some people do well in a high protein diet. And some people won't. It makes them more anxious. Some people do better with the low protein diet. So the keto and so forth. The exercise part. Some people will do better when you tell them to run a marathon. But if you tell that person who does not tolerate the dopamine very well, they will get anxious because what happens when you exercise, right? So, but you know, the whole point is if you recommend these things to your patients, but you see that they're having this reaction, then you can make a guess of what's going on. So, but you know, it's not all 100%. I do have some patients that are low metabolizer dopamine and they're on stimulants and they're okay. But I look back at why is that not happening? Their hormones are stabilized. In fact, I try to even maximize their progesterone level and they're fine and they're doing well and they're happy. So, but what we do, we have to think as providers, physicians, use our training to, not everything is a knee-jerk reaction. And so we have to know the interplay between all these things. Okay, so with genetic testing, yes, it does guide psychiatric meds if we really, really need to do it in the beginning. But address the underlying cause, the root cause, because that takes time. People ask me all the time, how long does it take for L-methylfolate to work? I always say, even with hormones, 90 days. And even then, it's not even like 100%. You know, that's why our program, the traumatic brain injury program in our office, is 1 year. We check the levels, when initial, third, sixth, sometimes ninth, in 1 year. And that's when we can try to, it takes the time to really stabilize it without doing any harm. Okay, so we talked about TMS, and most of the time, the patients that come to me have already done it. So what do? I use TMS in a way that to pull them out of their depression, and it works. But if we don't know the genetics, we don't know their hormones, they're going to be back again for another second round of treatment. And it's great. Yes, you'll make a lot of money, you know, but where are you as a clinician to say, what am I doing wrong? I have to take a step back. What is going on with this patient? Why they responded and why they're crumping. So we have to look at genetics. We have to look at their hormone levels, try to correct all that. And it's amazing. I've gotten some really, really good results. I may not have them back to do TMS, but that's okay. You know, we got plenty of other people that need that chair. Okay. All right. So stabilize the hormones. As I said, it's a part of traumatic brain injury program. You know, of course, very common in geriatric population, menopause, postmenopause, premenopause. As yeah, Betsy can probably give a lecture on that anyways, you know, when does the progesterone really go down? I was shocked to find out what age really it happened. So, and of course, if all else fails, we do use hyperbaric oxygen therapy. We do have a protocol from the physician in that documentary, Quiet Explosion, Dr. Scher, nice man. He created for us for all kinds of psychiatric issues, ADHD, brain injury, dementia, so forth. However, we also have to be careful with hyperbaric. We can't just stick somebody in the hyperbaric chamber. I learned that, you know, it's like you got to make sure they don't have any aerobic infections that you're going to feed the fire with. Okay. And Dr. Scher also talks about, like, I won't even put them in there unless they're eating right, sleeping right, not putting any toxins in their brain. So in essence, you have to still use all those things to address the patient wholly. It's not about just one. As you can see, it's not about just one. So we have to figure out what is the pattern in a patient. And every patient I have, it's kind of fun doing a cocktail, trying to figure out what works for them. And that's challenging, and I like it. It's fun. So it's giving me the passion for psychiatry that I used to have, you know, so that is all of it. So in essence, you know, when we talk about, to summarize everything, we talked about the depression panel, genetic testing, hormones, start with the supplements first, and lifestyle management, the TMS, hormone replacement, and HBOP. So we use all these modalities here. That's why we can get some pretty good results. Unfortunate thing is, you know, I just started learning this stuff. It just became a light bulb just last year, but it was just reading and reading and reading. Even I asked them, you know, some of the brightest minds in the country, and they still couldn't give me the answer. I just had to figure it out, you know, but ABCD, it was connecting. And I see it in my patients. I see how they react. And sometimes I don't even have to look at their genetics. I just ask them these simple questions. I think this is the problem, you know? And it's a good feeling, though, that you can actually verify it when you do run their genetics, you do run their labs. Okay, so any questions from this audience. All right, I know I'm giving you a lot, right? Okay, so you want to talk about cases? Okay, all right. Here's this one. I think Randy knows this one, but 71-year-old nurse. Worked in the psych unit, punched in the head, retinal hemorrhage, detachment, forced into retirement, depressed. Now she told me, did you know I was really suicidal, doc? I just didn't want to tell you because I didn't want you to Baker at me. I was like, well, I'm glad you didn't tell me that. And, anyways, so found out she was MTHFR deficient. So I added that, L-methylfolate. And she still kind of went downhill. So I added Abilify. So, there was some improvement, but not robust. And she went downhill again. So I added TMS. And what's, minimal, I would say, actually, it was pretty good, but still, she was not who she was. So she got lucky with me because this is when I learned hormone replacement, last year. And I thought about it, yeah, she's got a head injury, that's what's wrong with her. Did her levels, and interesting enough, she didn't need that much hormones. She was only on progesterone, and it's been almost a year. I check on her at least like once every 3 months. I'm good. I can I'm back to who I was. I'm doing these things. I'm happy. So as you can see, it's not just about one treatment. We have to do the whole thing. We have to make sure we don't have that missing link that's not there. So those are all the things that we can do to try to get her feeling better. All right, this one, interesting case. 30-year-old morbidly obese male on disability with treatment-resistant depression came to me from another provider, referred for TMS. Did that, yeah, it was good. And then I found out he was MTHFR deficient, so supplemented that. Still, he relapsed with depression. Mainly his main problem was anxiety. And so this is around the time that I actually learned all about TBI and hormones. I looked at he's 30 years old and his hormones were like 200, I was like, how does that happen? Because they were using his head, his body as a batting ram in football, starting from high school. So this is how a 30-year-old winds up in disability. So interesting enough though, his estrogen was high, but his testosterone is low. I did genetics, but it wasn't complete. So I ordered something else to it, but that didn't come back until he started having anxiety. So when I saw that low testosterone, I went ahead and treated it with, TRT, Clomid, DHA, anything to boost the testosterone. He got anxious about a month later. This is the problem. He was low COMT. He could not metabolize estrogen, and he can't metabolize dopamine. So he got anxious, moody. So I stopped the testosterone. I gave him a low protein diet. He was insulin resistant, told him to do relaxation exercises, and supplemented him with things that can modulate the dopamine's effects, that can stabilize you. So this is why, another thing, lithium orotate. Two things I'm using it for this patient. Because of their elevated dopamine levels, as well as lithium increases BDNF. So it helps patients to get healthy. And sometimes I use just lithium orotate, or I use 150 milligrams of lithium, nothing to hurt their kidneys, just enough to get their brain healthy, to give that boost. And those people who have the altered BDNF, there's been studies that lithium does increase the BDNF. So magnesium also, I give magnesium to all anxiety patients because it does stabilize the channels that causes anxiety and all that glutamate rush. So that's why. And up to now, he is no longer depressed, less anxious. He is losing weight. because his testosterone is still boosted, but I'm watching his estradiol using natural things to make sure that testosterone does not become estradiol so quickly. And yeah, insulin resistance, do have him on a couple of things like metformin. So that's about it. Do we have time for questions? Looks like, I think, yeah, we have 10 more minutes. Yeah, no, we got, actually, no, we're done. There's more cases, but I think I wanted to open up to like questions from anybody. I think Stephanie is gonna moderate all this, but I don't see it. So girl's gonna have to help me figure this out.
Yeah, we don't have any questions on Zoom yet, but if I do, I will go ahead. You guys can leave them in the chat box and I can go ahead and relay them to Dr. Damayo.
Okay, all righty then. Anybody have questions here? Yes, Connie.
What supplements do you give them? I mean, is there a certain brand or?
You know, it's interesting that you asked that question because I really don't, I'm not a person to promote any one particular brand. Most of the patients that come to see me, they're not even adherent to their treatment. So I'm happy if they go out and buy their, vitamin C and start taking it, so long as they're like taking the dose that I want them to take. And eventually, the more they educate themselves, the more they empower themselves, the more they really get into it, they'll start to research on their own what's a better brand for them. I mean, I can recommend things, but like, the whole point is I want them to just start taking care of themselves, to taking the recommendations that I give them. Okay. Yes, ma'am.
Okay, so you talk about genetics and which tests or which levels or the red light stuff, red light, green light.
Yeah.
What on there would you say to someone, I think you need to get family members in here, let's start looking at them, because we all know in mental health that certain conditions run in families that
Yeah.
you would recommend you get to it sooner rather than later.
I don't really have those recommendations, but I do know, when the patient sees what we're doing here with the genetics, they're like, can you treat my mom? She's worse than me. Or my brother, he really needs this, so, we don't make any, recommendations to test all of them. I also do this. I go by clinical. There are patients that I have, higher testosterone level. And I just had this case happen that, oh my gosh, she's on too much. So I lowered it. She crashed. I didn't lower it that much, but she crashed. I'm sure, Betsy, you can probably explain that to me better.
You do great with the testosterone.
Yeah. So I said, I'm sorry. I thought I was doing harm by, giving you too much. But she was irritable. She was fatigued. She couldn't concentrate. Her family started noticing what was going on with her, So I said, all right, let's get you back on what it was. And then we'll leave it there. So, my mentor for hormones, Dr. Mark Gordon, always said, treat the patient, not the labs.
Right.
So as clinicians, we're all taught, yes, we have to know the background. We have to know, protocols, so forth. However, if the patient is doing well on something, leave them. You will monitor them, every so often to make sure, and they'll call you if they're not doing well. And because they have that trust in you, say, you're going to take care of me, whether I'm down or up. And so I also have patients, I'm starting to do work for outpatient at Park Royal, and it's intensive outpatient of partial hospitalization. And it's funny because, there was one patient, I guess, he brought his genetic testing and I looked at it, I was like, well, I understand now why, none of this stuff worked for you. So I started telling everybody. And so every patient's coming in there, like, well, my genetic says I should do better on this. How are you doing on your meds? Fine, we'll keep it. We have to use our noggin, and we have to work with the patient to say, you're doing great. We'll keep it as is. If we need to make adjustments, we can make adjustments. So I think,
I have a question.
yes.
You also optimize their thyroid then too.
Oh, yeah. Oh, yeah. In our protocol, it's, we check
Do you
everything.
use desiccated thyroid?
No, I don't. We can, but like, some of my patients can't really afford all those like extra things outside. So I just go with whatever the insurance pays for it. They're doing fine. If they prefer that, well, we can go that route too. Yeah. I try to, give the patient the ability to be able to attain their treatment because I don't want to put that barrier on patients. So that's why
We
I
have
say,
a couple questions coming through on Zoom.
okay.
The first one is, what does genetic testing actually test for?
Lots of things. The one I use mainly is the one for mental health. So it's geared towards mental health. It looks at pharmacodynamics and pharmacokinetics, what patients are metabolizing them and what they're not metabolizing. So what I do is mental health. I'm sure there's genetic testing out there for all kinds of other, illness and so forth, but I use the one mainly for mental health.
Okay, and the second question is, what is the most common dosages for lithium orotate for the most beneficial effects?
I usually start them at 1 milligram and just titrate them to 5. Sometimes I give 10. Lithium orotate really doesn't have a lot of bad things, so you really can't do more harm than good with that. It has a lot of good benefits to it. That's one thing that's good about it. And we use it a lot too in kids. It does bring their anxiety and anger and impulsivity down, just low doses.
Is that over the counter?
Mhm. Yeah.
And how much of the magnesium do you recommend?
I usually recommend about 400 to start with. And I try to maximize them at twice a day if they can tolerate it, the diarrhea thing,
Say diarrhea.
Yep. So 400, but of course, there's always talk about you got to get magnesium citrate and threonate and all sorts. You can try to experiment with those. I think. I'm sorry.
You do lotions, like a lot of people have diarrhea and stuff. You haven't seen those?
Yeah, I have seen those.
Lotions and sprays,
Yeah. So you can try to figure out what works best for you. There are different options and liquids and so forth. I just wanted to mention that threonate supposedly is the best one that goes into the brain. Very good for insomnia.
Which one?
The threonate, magnesium threonate. Okay. All right. I think we have 4 more minutes or? Okay. All right. So anybody else have any other questions, concerns? How do you get involved in this? So.
I hate to ask about insurance, but
The
patients,
yeah.
referrals are gonna be asked.
Okay, well,
I'm sorry.
no, you know what? It's a good question because actually anybody who wants to do this program, before I even tell them, what needs to be done, I just do my evaluation. I run the tests, run the genetics, run the hormones. And there's times when I say, you don't need hormone replacement. This is your problem here. Interesting enough, though, yesterday, the case was they had great genetics, but why are they anxious, right? TBI, multiple TBI. This guy's in his 30s, okay? He was assaulted in a home invasion and self-medicating with alcohol and marijuana. And he said, I don't want to do that anymore. So, all right, we did everything. Genetics was perfect. His hormones was a wreck, total testosterone was low, free testosterone was low, thyroids were low. I mean, like cortisol was low. No wonder, he was feeling bad. So that's why you have to run all those things in order to pilfer, what is really going on with the patient. So I told him, well, you don't need any supplements. You need hormone replacement. The good thing is, we do a lot of trying to use your own physiology. There are times that we have to do testosterone injections and so forth. But the goal is trying to get their brain to be healthy and try to get to function again if we can. So, all right, I think that's about it. Anybody else have any questions?
Cards.
Yes. Oh, yeah. Yeah. So I mean, I'm sorry, I didn't really quite answer Randy's question. The thing is, the labs, the genetics, all of the initial evaluation, and all the follow-ups for med management is run through insurance. Okay. The value will become if I think you need hormone replacement. That's outside the scope of standard psychiatric practice, so we have to, do that cash. The price all depends on how vested you are in your treatment. And so, because I don't want that to be a hindrance for people. I want them to get better. That's the whole point. And it's great that I had a patient just email me last week, almost made me cry. She's like, you saved my life. I did TMS on her twice because the first time she crumped because I didn't understand her genetics, and I didn't appreciate how much of a traumatic brain injury she had, and so hormones down the tank. So I supported her nutritionally to make sure she responded to the TMS this time and addressed her hormones. This lady was high functioning, I think, therapist. I can't remember what she was, but she was in the mental health field, and she was forced into retirement because she was paralyzed from encephalitis. They told her she could never walk again, but she proved them wrong, Still walks with a limp, but hey, she's walking and she feels good. She's excited to tell me, I got a job as a sitter at the hospital. So I always want to celebrate people's victories because they don't want to be sitting in a corner, doing bad things. They want to feel good and they want to be able to also contribute. So that's another thing we do here. We do like to be people's cheerleaders, we cheer them on as far as they want to go. I just had a child who graduated high school this week. Anxious, so bad I had to put her on lorazepam. She's ready to get off of it. She's going to college, full ride. So sometimes if you think that it's difficult, you just have to look back and say, okay, how can I help you? So we can get there if also the patient too is vested in it. And those are the best patients to work with. They're really appreciative of what we do, and it makes it all worth why we do this. Okay. We just want people to be excited about what we do and excited about like how to treat people, the right way. So that's all I got to say. Thank you all for coming. I really appreciate it.